So thank you all for joining this evening. My name is Dr. Brianne Callanan. I'm a naturopathic and functional medicine doctor, and I have a primary focus of insulin resistance, resistant weight loss, and hair loss. But in tonight's presentation, we're going to be talking about the essential lab work to uncover the root cause of your hair loss. And we're going to go through the 6 most common root causes of hair loss that I see in my practice. If you are watching this presentation on Zoom, familiarize yourself with the chat feature. I'm going to be keeping an eye on the chat, answering your questions as we go. So if you could post in the chat where you're joining in from, I'm always interested to see what province or state everybody is from and how they heard about my practice. Make sure to also post your questions in the chat as we go. I'm going to try to answer them as we go, but if I don't get to it, I'll be reviewing everything at the end as well. In addition, can anybody who is on the Zoom presentation post in the chat if they can see my slides? I just want to confirm that so that everybody can see it, and then we'll get started right away. So for those of you who don't know me, my name is Dr. Brianne Callanan. I'm a naturopathic and functional medicine doctor, and I have a virtual health practice called The Wild Side Wellness. And I help individuals with low energy, metabolic concerns, resistant weight loss, and of course, hair loss. I am the author of the best-selling book called Wild and Free, and that's available on Amazon. And I have a private practice. I'm passionate about education. I love doing live education sessions like this to help you understand why you're experiencing the symptoms. And if you are a client of mine or if you've ever met with me one-on-one, you know I share a lot of slides. I love to review blood work with individuals because I truly believe that when you understand why something's occurring for you or why you're having the symptoms, it's like a light bulb moment. And it really makes sense when we're choosing a treatment plan if we can help you explain why we're recommending that treatment plan. I'm also a mom of 2. And I call myself a zookeeper because I have an abundance of animals in my life. I have 4 dogs, 2 cats, so my house is really full. So what we're going to be covering today is the 6 most common root causes of hair loss. There's going to be a lot of information on nutritional deficiencies, thyroid health, of course, hormones and insulin resistance, inflammation. We're going to be talking about diagnostic lab tests for uncovering why your hair is falling out in the first place, what to order, how to order, and what those optimal ranges are. And we're going to talk about some different treatment options, whether it's pertaining to nutrient deficiencies, thyroid-related concerns, autoimmunity, etc. So by the end of this presentation, you should have an understanding of different root causes of hair loss, how to get tested for these things, what to ask for if you want to take a list to your primary care, as well as how important it is to look at your labs from an optimal perspective, not just a normal perspective. So the first root cause that we're going to cover as pertains to hair loss is a big one, and it's nutritional deficiencies. We need key nutrients like B vitamins, folate, zinc, iron, and vitamin D. And if these are not within the optimal range, it absolutely can contribute to hair loss. Insulin resistance is a big one. This is a blood sugar concern that can lead to hair loss due to inflammation. But it's really interesting with insulin resistance in both men and women, we can see changes to the hormones as a result of that blood sugar concern. So I'm going to dive into what that is, how it relates to your hormones, and how it relates to hair. We're going to be talking about hormones because higher levels of androgens are a big contributing factor to androgenic alopecia. We're going to be talking about thyroid health, cortisol levels. Of course, high levels of the hormone cortisol or your stress hormone can cause hair loss. And we're going to do a brief touch on autoimmunity. First, I wanted to cover the science of hair growth, or what the hair cycle is. You have obviously tons of different hair follicles and different hairs on your head. And every single one of those hairs on your head is within a different growth phase. We want primarily the vast majority of our hairs to be in the growth phase. So ideally, 85 to 90% of hair is in that growth phase, and this phase can last 2 to 7 years. Then we have a transitional phase that can last a couple weeks. And of course, then we have the telogen phase. And this is where the hair is either resting or it's shedding. You should only have about 10 to 15% of your hair strands within that telogen phase, and it can last about 3 months. Now, the problem with hair loss, what happens is when this natural growth and shedding cycle is disrupted, stressors, nutrient deficiencies, hormones, inflammation can shift where the hair follicle is in the cycle. And if more of those hair follicles go into the shedding phase, that's where you're going to see some problems. Nutrient deficiencies and hair loss. I get a lot of questions about iron, so we're going to be doing a deep dive into iron deficiency. Vitamin D is really important for hair growth. Zinc is really important for hair growth and the quality of the hair. If you have low optimal or low levels of zinc, we can see poor quality hair texture, increased shedding. Vitamin B12 is another one. Vitamin B12 is a very important nutrient for carrying oxygen to the hair follicles. And folate, another B vitamin that is essential for the growth and division. And folate deficiency as well can contribute to hair loss. Iron, B12, and folate can all contribute to anemia, so it's important to have all of these tested. Let's start with iron deficiency. So iron deficiency symptoms are widespread, and you can have iron deficiency with or without anemia, and we're going to cover exactly what that looks like. Diffuse hair shedding is a symptom of iron deficiency, but also things like fatigue, brain fog, anxiety, lack of motivation, odd food cravings such as chewing ice. Some individuals can actually have cravings for gravel or dirt. Feeling cold, cold hands and feet is another symptom of iron deficiency. And this is extremely common. I think we need to do a much better job in diagnosing and treating iron deficiency because it is quite an easy treatment. Let's start with the definitions of what we run when we're looking for iron deficiency. I have a lot of questions on here about ferritin. Ferritin is the storage form of iron. How much iron you have in storage, what is your reserve? Serum iron tells us about the amount of iron that's in the blood. When we look at iron in the blood, iron cannot be free floating around. It has to be bound to something. So our iron is bound to something called transferrin. I think of transferrin like a bus. Your iron from the blood has to get on the bus. There's so many seats on that bus, and that's how iron gets moved around the body. Now, when we're looking at percent saturation, this tells us about how many seats on the bus are occupied by iron. So serum iron is your storage form of iron. Iron's what's available in the blood. Transferrin is how many buses you have to move the iron around. And then the percent saturation tells us how many seats on that bus or how many spaces on transferrin are being occupied. All of these markers are really important when we are evaluating iron deficiency. I want to know how much iron's in the blood. Of course, it's important, but we also need to know how much is in storage. How far away are you from becoming iron deficient? Or how much stored iron do you have for nice to have things like growing your hair? Iron deficiency anemia is a spectrum. So to call iron deficiency anemia, we need to see lower levels of hemoglobin, but that's at the very late stage. The first thing that's going to happen is you're going to deplete your stores of iron. You're going to deplete your ferritin level. After your body runs through the stores, then we start to see the iron in the blood go down. Then what happens in order to compensate is your body starts to produce more buses, more transferrin to move that iron around. We want to diagnose and treat iron deficiency when the ferritin starts to go down. We don't want to leave it all the way until the red blood cells, the mean corpuscle volume, the MCV, and the hemoglobin gone down. If that's happened, that's very late progression of iron deficiency, and that's a missed opportunity to resolve this quicker. Optimal ranges for iron. One really important piece here is that normal does not mean optimal, especially when it comes to good energy and hair growth. The reference ranges for ferritin depend on the lab, depends on where you go. And these reference ranges are really broad. I do not like to see a ferritin level under 80 when it comes to hair growth. 80 to 100 or 70 to 100 is where we want to see it for optimal. So if you have low levels of ferritin, that needs to be investigated. Your serum iron should be about 80 to 120, total iron binding capacity 250 to 400. Feel free if you're on your phone to take a screenshot of this, or if you want the slides after the presentation, I'm happy to send that over. This is what we need to see for optimal levels. Interestingly enough, there is a province in Canada called Ontario, and they recently updated their reference ranges for ferritin, which I think is fantastic. what we're seeing here is that they are now recognizing that a ferritin needs to be at least 100 for iron deficiency to be unlikely. There are many, many other provinces and states that are still considering a ferritin of 15 to be fine. This is not okay. This is not optimal, and it definitely will contribute to hair loss. A ferritin of 80 to 100 is where you want to see it. Now, it's not enough to just run the ferritin. And we're going to see some examples with respect to cases with that. Ferritin just tells you how much iron is in storage. You still need to know how much iron's in the blood, how it's being moved around, and how many of the transferrin are actually being saturated with iron. If you have lower levels of ferritin or you've been diagnosed with iron deficiency anemia, we have to understand and investigate why. Why are you not absorbing your iron? Is it because you have a lack of intake in your diet and we need to increase dietary sources of iron? Or is it because you are not absorbing? So I have lots of patients who they are consuming red meats and leafy greens and animal-based protein. They have an abundance of iron in their diet, but they're not absorbing it. So a couple things that you need to absorb iron, you need good stomach acidity, and vitamin C can be helpful. So on the slides here, you can see that iron is in the Fe3+ state or the ferric state when you consume it. That Fe3+ needs to first be converted to Fe2+ in order to be absorbed in the small intestine. You need stomach acid, so betaine HCl could be an option for individuals with low stomach acid, and vitamin C. So the very first step when you consume iron is converting it in the stomach to the absorbable form, and then once it's in the stomach, you can absorb it then. So you want to check if you have issues with absorption. Do you have low stomach acidity? Do you have gut infections like H. pylori that's preventing you from absorbing your nutrients? Do you have celiac disease or non-celiac gluten sensitivity? Do you have irritable bowel disease or Crohn's and colitis? Do you have blood loss in the stool? For individuals, this is really important. If you have chronic iron deficiency and you have been supplementing and things are not getting better, you need to investigate why you're not absorbing your iron either from your supplements or your food. One test that I commonly run in my practice is called the GI map stool test. So this is a DNA-based PCR test that looks for bacterial infections. It looks for H. pylori, which can reduce your body's ability to absorb nutrients, especially iron. It looks for leaky gut, inflammation. It looks for other gut infections, gluten sensitivity. So if you have chronic iron deficiency, you're supplementing or you have an abundance of iron in your diet, this test called the GI map stool test may be worthwhile running to investigate if there is any concerns in your gut. When it comes to iron supplementation, I use basic, very economical, easily accessible iron supplements in my practice. The vast majority of the research is showing that you need 60 to 120 milligrams of elemental iron. Now, each different form of iron that I have listed here on the screen contains a different amount of elemental iron per capsule. So you have ferrous fumarate, you have ferrous sulfate, ferrous gluconate. It does not matter which one you use, as long as you're getting the appropriate amount of elemental iron that's been shown to raise ferritin levels, which is 60 to 120 milligrams. There are more expensive forms of iron that are listed, the last three here. So your Ferromax, which is your polysaccharide iron complex. There's liposomal iron. There's heme iron. These ones are definitely more expensive. They don't have as much research on them compared to the first three. And if we look at a heme iron supplement, there's only 11 milligrams of elemental iron in that. So you can use heme iron as long as you dose it to make sure that you're getting 60 to 100 milligrams of elemental iron. But as you can see here for the price, $80 a month for the heme iron versus the more economical ferrous fumarate. I most commonly use ferrous fumarate in my practice, and I've seen really good results with it. The presentation, if you are joining over on TikTok, the presentation, I'm showing the slides on Zoom. I have no idea how to show the slides on TikTok, so if you want to see the slides, come join that webinar. If you can't figure it out, don't stress about it. Just send me a message. I'll send you the recording. So most commonly, again, ferrous fumarate is what I use in my practice. Ferrous fumarate is called Palifer, it's called Eurofer, it's called Jamfer. It doesn't matter if you go to a pharmacy and look for ferrous fumarate, you go on Amazon, it's really easily available and it's quite economical. Iron is not safe for everybody. You do want to make sure that you actually need iron because higher levels of iron, serum iron, or ferritin is also not ideal or safe. This is a screenshot of the American Association of Family Physicians for oral iron therapy. And this is where they are recommending the dosage of elemental iron required to treat iron deficiency anemia in adults is about 120 milligrams per day for 3 months. So again, just to kind of drive home this point, the most important thing, in my opinion, is to make sure you are getting the therapeutic dose of elemental iron. It doesn't necessarily matter the formation or the formulation of iron that you use, as long as it has that therapeutic level. When you're taking your iron supplement, the best iron supplement is the one that's going to be tolerated and the one that is taken consistently. Iron is better absorbed on an empty stomach, although if that causes your stomach to be upset or nauseous, then you can take it with food. You do want to avoid things that will reduce the absorption of iron. So things like dairy, coffee, tea, and medications about 2 hours. But again, the most important thing is to take it and take it consistently. So if you, in my opinion, it's better to take it even if you're going to have dairy, because you're still going to absorb some of it. But if you don't take the pill at all, you're not going to absorb any of it, obviously. Again, you can take your iron supplement with a source of vitamin C. That can help absorption. So things like lemon water or citrus or grapefruit, lemon, citrus fruit, that can all help with iron absorption. If you take an iron supplement, there is the potential for it to cause nausea, diarrhea, bloating, constipation. This can all be mitigated by drinking enough water, having enough fiber. Some individuals do best on an iron supplement combined with lactoferrin or magnesium citrate if it's causing some constipation, but all of these side effects with iron can be mitigated. There is some research that is showing that taking your iron supplement every other day is equally as effective as taking it every day. Now, when I speak to individuals in my practice, I don't like to overcomplicate things. I don't like to give individuals, a laundry list of supplements, and I don't want to, it has to be easy. I like things that are easy to do. So personally, for me, I find it much easier for me to remember to take an iron supplement every day than it is to take it every other day. If you can remember every other day, that's completely fine. But sometimes I'm like, what did I have for lunch? Or did I take my iron supplement yesterday or did I not? So I personally find it easier to take every day, but if you can figure out the alternate day dosing, that's fine too. Now, a couple other things. When it comes to iron, there are cofactors that are helpful for iron absorption and the movement of iron throughout the body. The two biggest ones are vitamin A and copper. So vitamin A deficiency is very commonly linked with iron deficiency. Vitamin A can enhance iron metabolism and it can help to increase iron storage. So there's research looking at supplementing with vitamin A and ferritin together, vitamin A and iron together. And we actually saw an increase in ferritin when vitamin A was used with iron. Vitamin A is not safe for everybody. It's not safe in liver disease. It's not safe in pregnancy. So you want to make sure that you're working with someone before taking a whole bunch of vitamin A. Copper is another one. This is a trace mineral that helps to move iron around the body. It helps to form your hemoglobin and it helps to form ferritin. Now, the reason that I have a picture of a desiccated beef liver on the screen, and this is an organ supplement, so it has liver, spleen, kidney, all within it. But what we know is desiccated beef liver is high in both vitamin A and copper. So for some individuals who are showing signs of vitamin A and copper deficiency as well as iron deficiency, I'm recommending an organ supplement or a desiccated beef liver. Now, you can also get vitamin A from food sources. Beef liver is going to be the highest. If you know how to cook it and you like it, go for it. I think beef liver is fantastic. Beef liver supplements usually do not contain enough elemental iron to raise ferritin, though. So most commonly, beef liver supplementations per 6 caps have about 3 milligrams. So that's very far away from the therapeutic dose of 60 to 120. Sweet potatoes, carrots, spinach, kale, red peppers, egg yolk, cantaloupe are also rich in vitamin A. And as you can see here, besides the spinach and kale, but a lot of foods that are orange or red or yellow in color are rich in vitamin A. So if you're taking an iron supplement, you want to include some of those foods to also get your vitamin A or a desiccated beef liver. Copper foods, again, beef liver is going to be the highest in copper. If you like beef liver, go for it. I've never cooked it or tried it, so I don't know if I like it or not. But I just think the supplement's a lot easier than figuring out how to cook that. Oysters, cashews, sunflower seeds, lentils, dark chocolate quinoa, spinach, sweet potatoes. These are also high in copper. So you can also, from a dietary perspective, you're working on your iron, you're doing an iron supplement, choose some of these foods to incorporate into your diet every day because they're rich in vitamin A and copper. Here's a patient case. So this individual had normal levels of iron in the blood. They had normal amount of transferrin, the buses that move iron around. They had normal percent saturation, but their ferritin or storage form of iron was particularly low. It was only 23. Again, we want to see it around 100 for optimal. So we put her on an iron supplement for 3 months, and here are the results after. So in just 3 months' time, her ferritin is now at 97, which is great. Not everybody has this great of a response in 3 months. For some individuals, like the next case we'll see, it's going to take 6 months. But this is why the follow-up blood work is really important to see what's working. We saw that the iron in her blood went up. And one thing I wanted to notice and point out here is the percent saturation is now high. This is because she's taking an iron supplement, and now the buses or the transferrin that she has are really saturated with iron. So this is a great opportunity for us to say, okay, great, you're done with your iron supplement. Just take your iron supplement the week of your menstrual cycle to sustain these levels. Here's another lab. This individual, their iron in the blood was only 35, their percent saturation was 9, and their ferritin was 5. This is a really good example of why all of the testing is needed and why is this so important. So she did her iron supplement for 3 months. So just to remember, iron was 35, now it's 139. Her percent saturation was only 9%, now it's 31. This is a really great response. If we only looked at the iron panel, we would say, okay, you're done supplementing with iron, everything's great. But she wasn't feeling better. And the reason she's not feeling better yet is because her ferritin, previously it was 7, now it's only 14. So she was so depleted in iron that now we've increased the iron in the blood, everything looks great, but her stores are still low. So she actually needs an iron supplement for longer. Again, explaining why it's so important to do that full panel, because it will help you understand, are things working, how much longer you need to take it, etc. I hope that makes sense with the vitamin or the iron. Does anybody have any questions about iron? Because I get a lot of questions about that. Next, we're going to move on to vitamin D. You want to test 25-OH vitamin D3, and the optimal range is 50 to 80. In terms of, let's go to, sorry, I jumped forward after I asked if there was questions. So what do I think of IV iron? I think IV iron is a great option for individuals who do not respond to iron supplementation. Now, if you do not respond to iron supplementation, I would be looking to why. What's going on in the gut? Do you have heavy menstrual cycles? Why are you not responding adequately? If it's the iron supplement isn't tolerated, maybe try a different form. Iron IVs can be helpful, but they don't address why that ferritin was low in the first place. So try to figure that out at the same time. So vitamin D. Vitamin D levels, when they're low, have been linked to androgenic alopecia, alopecia areata, as well as telogen effluvium. So all different types of hair loss can be associated with vitamin D. Zinc, when I'm looking at zinc levels, I'm running a red blood cell zinc. I'm looking at the amount of zinc that's in the red blood cells, not just the amount of zinc that's in the blood. I think the RBC zinc is more accurately reflective of your actual zinc levels versus the serum levels. Zinc is really important because it plays a role in hair repair, hair regeneration, and it supports hair growth. Zinc is involved in regulating the growth cycle of the hair, and if you're deficient in zinc, you can definitely see diffuse overall hair thinning. Same with iron deficiency. All nutrient deficiencies usually causes diffuse overall hair shedding, and we can also see it more along the temple. Zinc is really important too because it regulates the immune system and it can be beneficial in scalp conditions. So if you have dandruff or seborrheic dermatitis, looking to see if you're deficient in vitamin D and zinc is something to consider. Here's all the blood work that I run for nutrient deficiencies. I'm running the full iron panel, I'm running the ferritin, the CBC, B12, folate, zinc, vitamin D, and red blood cell magnesium. Now, if the iron is low, you might want to also consider testing vitamin A and copper. I usually always supplement vitamin A and copper when I'm suggesting an iron supplement. So I don't always test for those ones because I try to keep it practical and economical in terms of all of the blood tests. If everything was free when it came to lab testing, we would just run everything. But I try to prioritize the most important ones when I'm putting together panels for patients. So because I always supplement with vitamin A and copper, either through diet, I talk about dietary recommendations and food sources, or we're doing a desiccated beef liver and organ supplement, I usually don't include those ones. There is a really interesting DNA test called the trichogen test. And this is a test that is just a saliva sample. You ship it back to the lab. And this test will tell you, based off of your genetics, which nutrients you're more likely to be deficient in. So looking for B12, vitamin E, vitamin C, biotin, vitamin D, zinc, magnesium. This is really interesting because we can look at, okay, what does your genetics say? And then we can pair it with blood work to see where your actual levels are. Because just because you're genetically more prone to vitamin D deficiency, if you live in a sunny state, that may not actually be expressed for you because you're getting so much sunlight. But I have seen individuals who get a lot of sunlight exposure, but genetically they just can't absorb vitamin D from the sun. So I think the trichogen DNA test is really great, but it does need to be paired with blood work. Moving on to insulin resistance and hair loss. This is my favorite topic to talk about because this is where my practice started. My practice was all about insulin resistance, how insulin resistance can lead to resistant weight loss. But then a lot of my patients with insulin resistance were also coming in with androgenic alopecia, male or female pattern hair loss, and there is a huge connection between the two. So there is new studies that are showing about only 12% of the North American population is metabolically healthy. And that leaves a big percentage of the population that's suffering with insulin resistance. Insulin resistance comes before prediabetes and diabetes, and this can lead to things like obesity, high blood pressure, high cholesterol, and type 2 diabetes. And it's a really great opportunity for us to correct this. And there's really great diet and lifestyle strategies that can make a huge difference. Signs and symptoms of insulin resistance: resistant weight loss, especially weight gain around the midsection, mental health concerns, fatigue, anxiety, depression, oily skin. Females with insulin resistance, we can see acne or hair growth on the face. We can see hair loss in the head, cravings, irregular cycles, infertility, and of course, hair loss. You may have high blood pressure. You might have a high fasting glucose, high triglyceride levels, an HDL level that's low. Your healthy cholesterol is low. And if you're seeing more weight gain around the midsection, or you have a waist measurement greater than 40 inches in males, greater than 35 inches in women, that is a telltale sign of insulin resistance. So what is insulin resistance? When you consume carbohydrates, whether they're healthy carbs like fruits and vegetables or unhealthy ones like cake and cookies, your body is going to take those carbohydrates, digest it into glucose, and then glucose is going to enter the bloodstream and your blood sugar rises. That's all normal. Once you have higher amount of blood glucose, which is shown here as the red squares, your body's going to sense this and start making insulin. Insulin is shown on this diagram as the key. And the role of insulin is to help get the sugar into the cell. If the sugars go into the cell, everything's great. Your blood sugar comes down, you have good energy, your muscles work, you maintain your weight efficiently. The problem becomes when the lock and key becomes jammed. So now the insulin can't open the cell as efficiently. So the blood sugar stays high, and then you make more insulin, and the blood sugar stays high, so you make more insulin. And having higher amounts of insulin is the problem because what it says to the body is, okay, the sugar's in the bloodstream, it's not going into the cell, what's plan B? And higher amount of insulin will say, okay, let's take the sugar out of the bloodstream and put it away in storage. That's why we can see the triglycerides rise. We can store blood sugar in the liver, and we can see development of fatty liver disease. We can store sugar, of course, as body fat. So insulin resistance is a big problem. Now, you're here for hair loss. What does insulin resistance have to do with hair loss? Well, what we know is higher amount of insulin will reduce the liver's production of something called sex hormone binding globulin. I think of sex hormone binding globulin as like the catcher's mitt that binds onto your hormones such as testosterone and makes it inactive. So if you reduce the amount of sex hormone binding globulin, you're actually going to have more free testosterone floating around, which can cause the hair loss pattern, which we see in androgenic alopecia, female pattern hair loss or male pattern hair loss. So when you're looking at blood work, if you have high amounts of free testosterone, low amount of sex hormone binding globulin, you want to investigate, is insulin resistance the culprit there? In women, we can also see higher levels of insulin increasing DHEA. We can see that in males too. And of course, in women, we can see the ovaries producing more testosterone. So this whole picture, more insulin, more androgens, irritating the hair follicle, androgenic alopecia. That's how that connects. To screen for insulin resistance, you want to know what your blood sugar is, your fasting glucose. You want to know your A1C, which is your average blood sugar in the last 3 months. But you also need to know a fasting insulin. So we need to know how hard is your body working to control your blood sugar. Your A1C or your average blood sugar could be completely normal and you're still producing really high amount of insulin, and that's causing the hair loss. These are some optimal ranges. I don't like to see an A1C greater than 5.4. And, in terms of fasting glucose, fasting insulin, it does depend on your symptoms. So if your fasting insulin's a little bit higher, but you don't have hair loss, you don't have weight loss concerns or resistant weight loss, you don't have acne, you don't have hair growth in the face, and everything looks good from your symptoms, we may not need to treat it. It's really important when we're looking at optimal ranges to also pair those ranges with your symptoms. Here's an example of what can be seen on blood work. So this individual had a hemoglobin A1C of 5.6. In Canada, the Canadian Diabetic Association says 5.5 to 5.9 is just at risk. So this individual may have been told that their blood sugar is completely fine, or you're just at risk, hey, manage your diet. But look at the insulin. The insulin fasting is sitting at 221. That is really high. So this individual definitely has insulin resistance. What are the treatments? Doing a lower carbohydrate nutrition plan is often helpful. Intermittent fasting has some great research on it, but it depends on how you do your intermittent fasting. If you fast all day long and then have a terrible quality meal as your one meal and snack before bed, that's not how you want to do intermittent fasting. I would recommend doing larger meals less often and make sure that your meals, half your plate is vegetables. You have 4 to 6 ounces of protein at that meal. You have healthy fats with it. Larger meals less often. Snacking all day long, especially on carbohydrate dense foods, you're just going to be raising your blood sugar. You're going to be raising your insulin. Exercise, the more lean muscle mass you have, the better blood sugar control you're going to have. If you're not sleeping and you're highly stressed, that's going to raise your blood sugar too. So you want to look at that. There's supplement options. I like berberine. I like bifidobacterium B420 probiotic. That's got some good research on it, and myo-inositol. You absolutely can correct insulin resistance with diet and lifestyle. Some individuals benefit from supplements. And of course, some individuals also benefit from medications. Common medications that we see for insulin resistance, type 2 diabetes, prediabetes, are things like metformin and GLP-1s now, or tirzepatide, Mounjaro, Ozempic. You really want to understand where your insulin levels are, and then explore with someone, what are your treatment options? In my clinical consults, we go through, here's all the options, here's what the research has to say, here's the benefits and risks of each. And then the individual that I'm speaking with, they get to make the choice in terms of which option they want to go with. And then if we're doing diet and lifestyle, we can always repeat that blood work again in 3 months' time to make sure if it's working. If it's not working, okay, let's change the plan. But if it is working, let's continue with it. Other things for insulin resistance, make sure that you have an abundance of fiber in your diet from plants. Omega-3s from fish are fantastic. EPA, DHA, fish oil supplements, flax seeds, fruits. Berberine is one of my favorites for blood sugar control. Avocado, nuts and seeds, curcumin. When you're choosing carbohydrates, make sure that they are high in fiber, right? So lower glycemic index. If you're doing fruits, choose berries. Vegetables, whole foods are really important. And always set up your meal. You've got your protein, your half a plate being of vegetables, you've got your healthy fats. And if you're consuming carbohydrates, keep them about half the physical size of the protein. Berberine is one, again, it's my favorite one, so I just wanted to highlight this. Berberine in research has been shown to be as effective in metformin for lowering fasting glucose and hemoglobin A1C. It also has some positive benefits on LDL cholesterol, the quote unquote bad cholesterol, and triglycerides, and lowering of fasting insulin. It's not safe for everybody, so it can cause GI upset. For some individuals, dihydroberberine is better tolerated. You want to make sure that you're working with a professional or at least doing some extensive research. There are some drug interactions with berberine as well, so you always want to talk to your doctor. Let's go into hormones and hair loss. We're going to talk about high levels of androgens, so things like testosterone, dihydrotestosterone, DHEA. This can happen in men and women. And then I'm also going to do a dive into hormonal changes that happen during perimenopause and menopause for females. Let's do perimenopause 101. So perimenopause is the transitional period prior to menopause. And the thing that we have to recognize is perimenopause can occur up to 10 years prior to the onset of menopause. Some women can go through menopause at 45. So it's very reasonable to think at age 35, you could start to experience symptoms. And many individuals downplay their symptoms, they don't get tested, and they have no idea until they hit menopause that all of their symptoms were due to perimenopause. So I think testing here is really important. In perimenopause, it's like a hormone roller coaster. Estrogen and progesterone begin to fluctuate, and eventually they decline. Perimenopause is not this nice gradual decline in your hormones. Your periods get longer and shorter, and then they stop. That's not what happens. Usually periods can get heavier, they come more quickly, they become erratic. You can have hot flashes, vaginal dryness, itchy ears, joint pain. There's lots of symptoms that we can see with perimenopause. Menopause is defined as not having a menstrual cycle for a year's time. And perimenopause is that 10 years before. It is the low hormones that we see in menopause that increases the risk of cardiovascular disease, osteoporosis, and other chronic diseases. I love this diagram because perimenopause here in the middle, this is exactly what it looks like. In my private practice, I always test hormones. I do think it's valuable. I definitely think you can interpret the blood work if you know the individual's health history and when they went for the labs. The reason hormones are not recommended to be tested during perimenopause is because it looks like this. It's completely erratic. And I explain this to individuals. Just because your labs might look optimal when we run them doesn't mean the next cycle they're going to be perfect like this. Or just because they look not so great now doesn't mean that next cycle they're going to not be better. So I test them still to see where things are. I like testing. I think it's valuable, but I understand why some practitioners say don't test hormones. It's because they fluctuate all like this. But if you know the patient's health history, you know when they went to do the blood work and when their period came, I do feel you can interpret it quite accurately. Here's why I test hormones in perimenopause. I want to know where the hormones are. Sometimes what I see in perimenopause is actually estrogen dominance. So usually what happens is you begin to have erratic ovulation. So you're not ovulating as much, so you're not getting as much progesterone. So at the start of perimenopause, you could actually have higher levels of estrogen compared to progesterone and compared to other hormones. I think testing in perimenopause is also really important because it can guide HRT dosaging, as well as the symptoms of perimenopause could also be symptoms of a thyroid disorder or symptoms of high cortisol. So having a comprehensive look at everything at all at once is really valuable. I usually run blood work when it comes to hormones. There are other means to test hormones like the Dutch testing. I think the blood work is faster, it's more economical, and it has more research to support it. I also think the Dutch test is amazing. It can look at how your hormones are being metabolized. It looks at your cortisol curve throughout the day. If I'm having any discrepancies with the blood work, or if a patient wants to run the blood work and the Dutch test at the same time, I think that's amazing. But the Dutch test takes about 4 to 6 weeks to get back. So it's not really practical to be doing urine testing all of the time, and it's cost prohibitive. So I think the Dutch testing is great. But if it's cost prohibitive, because it is around $400, and you just have access to the blood testing, I think you can also get so much information just from blood work. Menopause affects the following. Menopause affects your cholesterol, your blood sugar, your inflammation, kidney and liver functions, your adrenal and thyroid, and your hormones. And all of those can impact your hair as well. Estrogen is really important because it lowers inflammation. Estrogen also is protective to our muscle mass. It's not just testosterone. We need estrogen as well. So when your estrogen levels begin to decline, what we see is inflammation goes up, muscle goes down, body fat, especially the weight gain around the midsection, can go up. And all of this put together creates an inflammatory state on the body, and inflammation can result in hair loss. Inflammation, we can measure this as HSCRP or ESR on blood work. Inflammation will prevent weight loss. It will cause hair loss. It's associated with increased risk of autoimmune conditions. It disrupts your hormones. And the more inflammation you have in your body, we actually see more hot flashes and more severe hot flashes with that as well. Now, how does low estrogen particularly impact your hair? So estrogen plays a key role in the growth phase of your hair. So if you've ever been pregnant, normally when you're pregnant, you have you have higher amounts of estrogen, but normally you have really great hair. And postpartum, it's that drop in estrogen that can cause the hair shedding. So we can see that same drop in estrogen in perimenopause and menopause, and we can see the same concern as hair shedding. Estrogen is also really interesting because it influences how sensitive your hair follicle is to androgens like DHT, testosterone, DHEA. So in androgenic alopecia, which is hair loss caused by high androgens, usually that's the part line widening, the crown. You can also see the temples here. In androgenic alopecia, sometimes we focus just on the androgens and how do we block the androgens and how do we lower the androgens. But we also need to consider estrogen and the influence that it has in the follicle sensitivity to those androgens. Estrogen definitely can cause hair loss when it's withdrawn. You also have to remember that certain forms of birth control, which contain estrogen, when you stop them, that can cause hair loss. Doesn't mean that you have to be on birth control forever if you don't want to be, but it's just something to consider. Depending on the type of birth control that you're on, it may have positive impacts for your hair or negative impacts for the hair. Progesterone is also important because it can antagonize or inhibit androgens as well. So when we're looking at androgenic alopecia in perimenopause, we have to understand, is it the androgens being high that's the problem? Or is it actually the estrogen progesterone being too low, so we're not getting the balance of the estrogen progesterone to the androgens? And if we can correct all of this, then what we can see is positive impacts on the hair growth. Androgens, so things like testosterone, dihydrotestosterone, DHEA, these are the types of hormones that cause male and female pattern baldness. Again, that part line widening, the crown, the sides. Everybody has a different sensitivity to these androgens, which is also important. So just because your blood levels of androgens are normal doesn't mean that you don't have increased sensitivity. I also have patients come to me and they say, my androgens are normal, but all the doctor looked at was the androgens. Again, you need to know the androgens and the relationship to the estrogen and progesterone. Because as the estrogen and progesterone decline, you will see a relative increase in the androgen activity, which can lead to increased hair shedding and increased rates of androgenic alopecia and perimenopause. Now, what about telogen effluvium in menopause? So telogen effluvium is diffuse overall hair shedding. It usually is short-lived. It usually occurs about 3 months after a stressor or some sort of hormone change, and it usually does resolve on its own. But what we do know is that hormones can impact telogen effluvium. So when we see the hormone fluctuations in menopause, that comes with significant increase in stress and anxiety, insomnia for some individuals, joint pain. All of this together creates inflammation in the body and creates additional amount of stress or raises the hormone cortisol. So if you're going through perimenopause and your symptoms are quite bothersome, they're increasing your quality of life, that in itself can be a stressor which can trigger telogen effluvium. Another interesting thing with estrogen and progesterone is they can impact the health of the scalp. And the scalp is really important because that's where the hair follicles receive their nutrients and their blood supply. So if you have reduced circulation to the scalp because your hormones are low in perimenopause and menopause, that can lead to dry, flaky skin. It can lead to increased hair loss due to lack of circulation. And a compromised scalp is not a great environment for hair growth. So in summary, you are going to have a shorter hair growth phase when you are in perimenopause and menopause and your estrogen and progesterone are lower. If your hair is not growing as much or it's not staying in that growth phase as long, we can see hair shedding faster than it can grow. We also know that lower levels of estrogen and progesterone can cause an increased sensitivity to androgens like DHT and testosterone. Concerns with scalp health can be impacted by your hormones. And then, of course, just the stress and anxiety and the lack of sleep and the inability to regulate your blood sugar and the inability to handle stress as well, which comes with perimenopause and menopause, all of that stress and changes on the body can cause hair shedding as well. Now, what about high androgens? So androgens, again, testosterone, DHT, DHEA, these can all contribute to androgenic alopecia. And it's important that you have all of these tested to understand what's going on. High levels of androgens can cause male and female pattern hair loss. We can also see acne. We can see hair growth on the face for women, more oily skin, irregular periods, or ovarian cysts. High levels of androgens can be caused either by an overproduction, so your body's just making too much, or if you have less of that liver protein, sex hormone binding globulin, to bind onto your testosterone to make it inactive, we're going to see more free testosterone. Some individuals as well have a genetic superpower to convert testosterone to dihydrotestosterone. Dihydrotestosterone is the super testosterone. It significantly irritates the hair follicle and definitely contributes to hair loss. So what we want to understand is, do you have too much testosterone, or is your testosterone just not being bound to make it inactive by sex hormone binding globulin? Or maybe your testosterone is very rapidly converting to dihydrotestosterone, and that's contributing to the hair loss. And we also want to understand, maybe your testosterone is fine, but your estrogen and progesterone are low and not balancing it. The blood work can be really helpful for unpacking all of this and discovering exactly what is the issue for each individual. This is a great diagram to hopefully explain a little bit more about sex hormone binding globulin. So I think of sex hormone binding globulin, again, it's like catcher's mitt that binds onto hormone. Another analogy that might be helpful is thinking of sex hormone binding globulin as the school bus. When my kids get on the school bus, I know that they're going either to my house or school. There's no pit stops on the way. They cannot get off that bus. Sex hormone binding globulin tightly binds onto testosterone. It's not going to be free. It's not going to be available. Testosterone can also be bound to something called albumin. This is more like the city bus. So you pull the lever and you can get off at different stops. So albumin, yes, it's bound, but the testosterone can easily get off that bus if it needs to. But the sex hormone binding globulin is heavily bound. Now, again, we have to test for sex hormone binding globulin, but we have to ask the question, maybe you have so much free testosterone because you don't have the sex hormone binding globulin binded on. Okay, well, what can lower sex hormone binding globulin? Remember, it's the insulin resistance. So when we look at androgenic alopecia, we need to uncover what's going on, but also the reason why. Just to say somebody is genetically more prone to this, it runs in their family, take a medication for the rest of their life, I don't think that's a really great approach. I think it's really important that we figure out why this is occurring, because it's an opportunity to diagnose insulin resistance and treat it. Insulin resistance is not only a contributing factor to androgenic alopecia, it's also cardiovascular disease, which is the leading cause of death. What can cause low sex hormone binding globulin? We talked about the insulin resistance. Patients with PCOS often have lower amounts of sex hormone binding globulin. Hypothyroidism. So if you have low thyroid function, you can have lower sex hormone binding globulin. Now you have more free testosterone and you present with androgenic alopecia, but it's actually the thyroid condition that's driving that. Resistant weight loss or obesity, we can see reductions in sex hormone binding globulin, and liver disease. So if you have non-alcoholic fatty liver disease and your liver's not functioning optimally, remember, it's your liver that produces this binding protein to make the testosterone inactive. Certain medications can lower sex hormone binding globulin. You can have genetically lower levels of sex hormone binding globulin. High levels of cortisol or high levels of stress can contribute to this. So again, I find this interesting where individuals will say, oh, it's just halogen effluvium, it's just stress-induced hair loss. Go home, there's nothing you can do. Well, what did the stress do? Did the stress cause inflammation and cause the hair loss? Did the stress change the hormones and cause the hair loss? Did the higher amounts of cortisol reduce the sex hormone binding globulin, so now there's more free testosterone? I definitely think with halogen effluvium, we can do a way better job in figuring out the root cause. I got a question the other day, yesterday actually, on birth control and sex hormone binding globulin, so I wanted to include this slide. Depending on the type of birth control, some birth control increases sex hormone binding globulin, so thus your testosterone is going to be more bound up, so that may be helpful for hair loss. Whereas other forms of birth control can reduce sex hormone binding globulin, you have more free testosterone, and that may not be as helpful for hair loss. In addition, this is why certain forms of birth control can significantly impact libido. So if you're taking a birth control, it's raising your sex hormone binding globulin, you're binding up your testosterone, now it's inactive, thus we can see lower amounts of sex drive associated with that, so something to consider. The next thing I wanted to talk about is how testosterone is converted to dihydrotestosterone. So testosterone is converted to dihydrotestosterone, which is the super testosterone that binds to the androgen receptor and is highly associated with hair loss. Some individuals have a genetic superpower to rapidly convert their testosterone to dihydrotestosterone. In some cases, we can actually inhibit this enzyme, the 5-alpha reductase, to help reduce this. And that's where medications come in, like finasteride, dutasteride, or natural health products like saw palmetto, Pygeum, etc. Now, the trichogen test, so we talked about this DNA test as being beneficial to uncover what nutrient deficiencies you might be genetically more prone to. This trichogen test can also tell you if you have this genetic superpower to convert testosterone to DHT. Based off of your DNA and what's predictive of this test, we can better choose treatment options for you. So some individuals overproduce testosterone. Some individuals take their testosterone and convert it to dihydrotestosterone. Based off of your DNA, we can more efficiently choose a medication option or a supplement option if we're looking to treat androgenic alopecia. Certain medications. I wanted to do a quick review of medications that are often used for androgenic alopecia. Then we'll talk about supplements that are commonly used for androgenic alopecia. Spironolactone is one. So spironolactone acts to block the androgen receptors. It can also reduce overall androgen levels. Now, it's usually prescribed more in premenopausal women, and it can also help not only with hair loss, but PCOS, hair growth on the face, and acne. Because spironolactone can change the balance between your androgens and your estrogen, Sometimes you can see irregular periods, spotting, breast tenderness, and in rare cases, you might can see some lower levels of potassium levels because this is a diuretic. This cannot be used in pregnancy, and it may actually worsen estrogen dominant conditions like fibroids and endometriosis. So when you're looking at choosing a medication, you want to understand which medication is going to be the most appropriate for you. Just because your hair loss looks like androgenic alopecia doesn't mean it's not an iron deficiency if you don't run the blood work. So I think looking at the blood work makes a lot of sense, and then reviewing all of your options with somebody. Okay, what are my medication options, pros and cons? What does the research have to say? Excuse me. What are my supplement options? What does the research have to say? Now, medications like finasteride and dutasteride, these work a little bit different. So spironolactone blocks the androgen receptor and blocks or reduces the amount of androgens that are produced by the ovaries. Finasteride doesn't do any of that. Finasteride inhibits the 5-alpha reductase enzyme, preventing your testosterone being converted to DHT. So it's important to know, do you have a DHT issue? Do you have an overproduction of testosterone issue? And the trichogen test, that DNA test, can really help pinpoint which issue you have and which medication would be most appropriate. Finasteride is not approved to be used in women. It is only FDA approved in men, but it's often prescribed off-label for women. This does come with some potential significant side effects. So again, you have to weigh the pros and cons. It's not always great to reduce DHT to really low levels. That can cause mood changes. It can cause breast tenderness in females. It can cause decreased libido in males and females. It can cause erectile dysfunction. And finasteride has some pretty significant risk when it comes to pregnancy. So it's often not prescribed in women who are premenopausal. So that's something to consider. Now, what are the natural DHT blockers? So unfortunately, when it comes to natural health products, we just don't have as much funding to support research on natural health products. Another unfortunate thing is women are often excluded from a lot of the studies. So when we're looking at natural DHT blockers, things like Salpimento, Pygeum, stinging nettles, lycopene, the vast majority of these studies are all using data from men. And that doesn't necessarily mean that we could take that same data and apply it to women. Now, again, if you want to use natural health products and you want to use natural DHT blockers, I think that is absolutely fantastic. Let's go for it, but let's run the blood work before and after so we see if we're seeing a positive change. When it comes to the research, I believe that Salpimento has the most research on it. Dosing is typically around 320 or 640 milligrams a day. Pygeum has a lot of great research on it. These are the ones that I've listed them in order. Pumpkin seed oil is at the lowest in terms of its ability to block the conversion of testosterone to DHT. This is because the study on pumpkin seed oil that compared pumpkin seed oil to finasteride, it was not a well-conducted study at all. The other issues with that study is it wasn't just it wasn't just pumpkin seed oil that they used. It was a combination product. So I think the whole study on pumpkin seed oil showing that it had a 40% increase in hair density, similar to finasteride, I don't think it does. Pumpkin seed oil has a lot of great benefits in terms of it's high in vitamin E, it's high in zinc, but will it grow your hair back 40% more dense? I really don't think so. But using the Salpimento Pygeum stinging nettle could definitely be an option. When it comes to choosing a product, a natural DHT blocker, what you want to look for is a brand that does third-party testing and does standardization. So for instance, when it comes to Salpimento, you want to look at the back of the bottle and you want to see the percent of the active ingredient in it. The same way we talked about iron. So there's many different types of iron and they all have different potency in terms of the amount of elemental iron. Salpimento has different potencies in terms of the active ingredient. So you want to look for standardization and you want to look for a company that does third-party testing. Whether or not you use a single ingredient product or a combination product, I think is very individualized. Here are a couple options. These are brands that are all third-party testing. Prostate Supreme by Designs for Health, you might be thinking, what does prostate have to do with hair loss? When we look at saw palmetto, zinc, nettle, lycopene, chrysin, a lot of these ingredients have been shown to be beneficial in benign prostatic hyperplasia. And I find supplements that are marketed for prostate health, they have the same ingredients and they're more economical than products that are promoted for hair loss. Anytime you see a product for hair loss or weight loss, it comes with a higher price tag in general. So you're better off to look for prostate formulas, even though you might not have a prostate, but it has the right amount of the active ingredients in it. So those are 3 to consider. When it comes to thyroid and hair loss, 60% of individuals who have a thyroid disorder present with hair loss. 80% of individuals with a thyroid disorder report weight gain. 75% present with fatigue. 65% see mood changes. 55% see muscle wasting. And more than 12% of the US population will develop a thyroid condition within their lifetime. And interestingly enough, women are 5 to 8 times more likely to be diagnosed with thyroid disease than men. So this is something that I recommend testing for each and every year. You want to have a full thyroid panel. You want to look at TSH. So is the brain communicating to the thyroid gland? You also want to know, once the brain sends the signal, how much thyroid hormone is the thyroid producing? How much T4 do you have? How much T3 do you have? And recognizing that that full thyroid panel gives you the best understanding of what's going on. Very interesting to me is about 20% of your thyroid hormone is activated within the gut. So it's really important if you have digestive concerns in combination with a thyroid disorder that you're also considering that. We also know that the liver is really important for converting and activating your thyroid hormones. So you want to look at your liver health, and the gut microbiome is important for converting your your inactive T4 to your active T3. So gut health and liver health definitely plays a role when it comes to the thyroid. I love this diagram. It helps to explain different nutrients that contribute to thyroid health. So once your brain tells your thyroid to make thyroid hormone, that's the T4 that you see here. Then what has to happen is the T4 needs to be converted to T3. That's your active thyroid hormone. This is what binds to the cell and turns it on. So we want a lot of T3, not too much, but we want more T3. There is another option. Your T4 could be converted to reverse T3. Reverse T3 binds to the cell but doesn't turn it on. It's like a game of musical chairs, but the reverse T3 is like high schooler and the T3 is in middle school. So if you have too much reverse T3 binding to your cells, even if you have enough T3, you could still present with symptoms. Now, recognize that stress, trauma, inflammation, toxins, infections, liver kidney disorders, low-calorie diets all push you down more this reverse T3 pathway. So when I see higher amounts of reverse T3, a patient could be still seeing all of the thyroid symptoms, even if their other thyroid labs are normal. And then we have to investigate the root cause of why the reverse T3 is up. Again, there are certain types of bacteria that are more commonly found in thyroid patients. H. pylori, Blastocyst hominis, Yersinia, leaky gut, small intestinal bacterial overgrowth, low stomach acid. So anybody who comes to my practice with a thyroid disorder, I'm often recommending a stool test like the GI map to look for any of these gut infections. When it comes to thyroid testing, it's really important to test consistently. So test first thing in the morning, test fasted. You need to avoid any supplements with biotin 2 days before you run your thyroid panel. And it's important when you are doing your thyroid test, if you are on a thyroid medication, ask your doctor, are you supposed to take your thyroid medication before or after? Because certain types of thyroid medications can influence your lab testing. Another thing about thyroid testing is we know that TSH can be significantly higher in the morning between 8 and 9 a.m. And then it can spontaneously drop in the afternoon. So what this study actually showed is that 50% of participants who completed their blood work in the afternoon they would have been missed for hypothyroidism. So it's really important that if you are testing your thyroid, test in the morning between 8 and 9 a.m. and make sure to avoid any supplements with biotin 2 to 3 days before. Moving on to stress, cortisol, and hair loss. High cortisol, the stress hormone, is a big contributing factor to telogen effluvium or diffuse overall hair loss. Stress could be from hormone changes in perimenopause. Stress could be mental emotional stress. Stress could be nutrient deficiencies. Stress could be processed foods and high sugars in your diet. Stress could come from insulin resistance. Stress could come from an autoimmune condition. And there's not a magic pill for higher amounts of cortisol. You really need to figure out what is that underlying cause and how do you address it. There are some supplements like magnesium, adaptogens, GABA, L-theanine. I think these are all great, but no amount of supplement is going to make up for the need for lifestyle when it comes to cortisol. On the screen here is a picture of a cortisol curve. So cortisol should spike up in the morning to kind of give you energy, get you out of bed, wake you up for the day, and then cortisol should be low towards the end. It is best to test for cortisol with urine or saliva testing because that's very easy for you to do at home multiple times in the day. Obviously, it's not conducive to get in for blood work 4 times a day, but it's very easy to do a urine test 4 times a day. If you do your cortisol testing 4 times a day, we can create this nice cortisol curve picture. We want to know, is your cortisol low in the morning? Is it high in the morning? Is it high before bed? So you're feeling tired but wired. You're waking up between 3 and 4 a.m. The urine test, which is the Dutch test, can paint a really nice picture when it comes to cortisol. Stress, again, it's not just mental emotional stress, infections, poor nutrition, lower amount of protein in your diet, chronic caloric restriction, high blood sugar, chronic inflammation, all of that can cause stress on the body. Another interesting thing about the hormone cortisol is too high of levels of cortisol can actually mess with all of your other hormones, especially progesterone. So what you can see here is cortisol is actually made from progesterone. So if you have high levels of cortisol, that can actually steal your progesterone, making it lower. Cortisol should be the zen, loving, sleepy hormone that you have high amounts before your menstrual cycle. If you don't have that calm, zen, sleepy, loving hormone before your menstrual cycle, you could experience irritability, mood changes, insomnia before your menstrual cycle. So it's really important if you have low progesterone to also consider the impacts that stress might be having. Ways to reduce stress. Exercise is great, getting outside, fresh air, but don't overdo exercise. Yoga, gratitude. I'm a huge fan of psychotherapy. My psychotherapist has been a game changer for me, and I actually started with a psychotherapist when I was feeling really great. And then, of course, unforeseen circumstances happen, and she was a great support to help me get through that as well. You could do baths, self-care, connect with loved ones, and I will talk about a couple supplements that I like for stress, but they're not exactly what you might be thinking. So a lot of my patients, because I do treat resistant weight loss, they are on some form of caloric restriction. And one thing that individuals forget is when you're losing weight, not consuming enough micronutrients and protein is a stress on the body. When you're losing weight, the last thing that you want to do is tap into your muscle mass. So one way to protect the body, if you are on a weight loss journey and there is a little bit more stress from that weight loss, or you're seeing hair loss with your weight loss journey, make sure that you are getting adequate protein. I want individuals to ensure they are getting 0.7 to 1 gram of protein per pound of ideal body weight. So if your ideal body weight is 130 pounds, aim for about 130 grams of protein. Supplement with amino acid, a collagen powder, a protein powder to get those numbers up. Powdered bone broth. I actually just saw Organica's powdered bone broth, 2 tablespoons of it, kind of makes like a chicken soup, put boiling water in it. That had 15 grams of protein. So make sure if your stress is coming from caloric restriction or weight loss that you're getting enough protein. Lack of sleep is a stressor. So make sure that you are getting at least 7 to 8 hours of undisrupted quality sleep. If you are not sleeping well, it's important to figure out what is your strategy to address that. Do you need adaptogens, ashwagandha, L-theanine, GABA, magnesium? Do you need melatonin? Really, I cannot emphasize enough how important sleep is. I do make a product called Cortisol Reducer. It has the ashwagandha, the L-theanine, the GABA. It supports healthy cortisol levels. It's really great during times of stress. I find it's really helpful for food cravings. It can help support libido as well with the banana leaf that's in it. And this one I personally use more periodically. So if I'm undergoing specific areas of stress, I'll add this in. But the one that I use more consistently is actually the Relax and Focus. So I have Relax and Focus in here now. Public speaking, live events are, I love interacting with you guys, but they're definitely anxiety producing for me. And I find the Relax and Focus, it's this pink drink that tastes amazing, GABA, L-theanine, magnesium, and it has myo-inositol in it to stabilize your blood sugar. So I would say the Relax and Focus is a non-negotiable for me. I mix it with the amino acids and I drink that every day. And then the cortisol reducer, I'll add in a little bit more if I'm seeing cases of higher stress or times of higher stress. The last section of our presentation tonight is about autoimmunity. I'm going to go through these a little bit quicker because I recognize this doesn't impact everybody. Not everybody has autoimmune conditions, but I just wanted to say autoimmunity or having autoimmune conditions impacts hair loss through a variety of ways. Autoimmune conditions are when the immune system mistakenly attacks your own body's cells. There is an autoimmune condition called alopecia areata, where the immune system mistakes the hair follicles as foreign and starts to attack them. That can lead to bald spots or patches in the scalp. Now, alopecia areata isn't as common compared to telogen effluvium and androgenic alopecia, but it is still something that impacts some individuals. In severe cases, when there is scarring, the hair loss is harder to regrow back. But that's something that the trichogen test could also really help with because there are some medication options that may be effective for you. So again, alopecia areata is when the immune system goes a little bit wild and starts to attack the hair follicle as foreign, and then we see bald patches of hair loss. What I wanted to mention, because autoimmune conditions are on the rise, so Hashimoto's, Graves' disease, celiac disease, rheumatoid arthritis, type 1 diabetes, with any autoimmune condition, there is a higher risk of developing other autoimmune conditions. So if you have type 1 diabetes or celiac disease or psoriasis or Crohn's or colitis or rheumatoid arthritis or Hashimoto's, you have a higher chance of potentially developing alopecia areata. So that's something to keep in mind. Lupus is one. This is an autoimmune condition where the body's attacking your healthy tissues and organs, including the skin and the hair follicles. That can cause hair shedding. And running an ANA, which is a autoimmune test for screening for potential autoimmune conditions, could be helpful here. Now, hair loss in lupus can be temporary. But if there's scarring present, it's usually harder to resolve that, although there are some medication options. There's some evidence for PRP or exosome therapy as well as microneedling could be helpful. Now, in patients with Hashimoto's, an autoimmune condition that causes hypothyroidism, those thyroid hormones being low definitely can cause hair loss. But the good news is once the thyroid levels are normalized, either through supplements or medications or correcting the root cause, usually that hair loss pattern is resolved and the hair does grow back. Psoriasis, this impacts the health of the scalp. So you might see red patches at the level of the scalp. This can cause hair loss. So it's important to have a look at your scalp if you're seeing any sort of hair loss. Look for red patching skin. If you have a past history of psoriasis, this is something to consider as well. Once the inflammation is addressed and the flares are reduced, the hair does often grow back. Rheumatoid arthritis. What I see with rheumatoid arthritis is the hair loss is often as a result to the common medications that are used in this condition, whether you're using chemotherapeutic agents or you're using immunosuppressant drugs, those can cause hair loss. But again, with any sort of arthritis or inflammation, once you get the inflammation under control, there is a great chance for the hair to grow back. Celiac disease, this is an important one. So celiac disease is an allergy to gluten. You can't eat gluten-containing products. If you have celiac disease, what we see is a higher probability of nutrient deficiencies, which we talked about at the start of our presentation. Patients with celiac disease more commonly have low levels of vitamin D, low levels of iron, low levels of zinc, and B vitamins, all which can cause hair shedding. This is a telogen effluvium diffuse overall hair loss pattern, but it is temporary. Once you follow a strict 100% gluten-free diet, you get your vitamins and minerals back up, you can see improvements in your hair. Type 1 diabetes, this again, it's either the inflammation that can cause the hair loss in type 1 diabetes. It's the circulation issues that we see with type 1 diabetes that can damage the small blood vessels. You're not getting enough blood flow to the scalp, and that can cause an oxygen supply issue and the hairs to prematurely fall out. Now, I know we did the autoimmune testing a little bit quicker. Autoimmune is a little bit different in terms of what we treat, but I would recommend definitely looking at the health of the gut microbiome. How to get tested. So to make things easier, I put together a hair loss blood work bundle. You can click on that in my profile, take a screenshot, ask your primary care to run those labs. If there's any issues with them running the labs, Rupa Health is a really great option. So Rupa Health is a wholesale lab company. They connect patients with the lab. It's LabCorp that they use, and the pricing is actually really good. If you compare this cash pay pricing with some of the insurance pricings and the deductibles, it's often quite higher. So to get the full overall custom hair loss bundle with your nutrients, your hormones, your screening for insulin resistance, a full thyroid panel, your lipid panel, inflammatory markers, thyroid antibodies, it's around $400 to $450. I don't know the exact price of it off the top of my head, but that gives you everything. The other option is if you've already had blood work done and you're just missing a couple markers, if you want to set up a one-on-one consult to review your labs that you already have, decide what else might need to be run and your different treatment options, we do that as well. The GI map stool test, you can also order that through Rupa Health. So if you have chronic nutrient deficiencies, if you have autoimmune conditions, if you have thyroid disease, it might be worthwhile looking at the digestive health, or if you have GI symptoms, if you have gas, bloating, heartburn, indigestion, constipation, I think this is a great test to consider as well. The trichogen test, I'm just showing these slides so you get an idea of pricing. I don't know why I don't have the hair loss blood work bundle pricing. I know it's between $400 to $450. The GI map is around $460, and the trichogen test is $375. So that's the DNA test. If you're going to do one testing, I would recommend the blood test. That's the most comprehensive. It gives us the most insight. I'm a big fan of test, not guess. I really do think that if we can get to the root cause of why your hair loss is occurring, not only can we choose the right treatment to improve the health of your hair and resolve your symptoms, but we may actually support many other things, right? So if we identify low hormones in perimenopause, your quality of life will get significantly better. Your sleep will get significantly better. Your mental health, your risk of osteoporosis when those low hormone states are addressed. If your androgenic alopecia is coming from insulin resistance, resolving that will reduce your risk of type 2 diabetes, cardiovascular disease, Alzheimer's, dementia, and certain types of cancers. So I see hair loss as one of those symptoms that can really tell us a lot about what's going on and significantly improve the quality of the life of the individual. Oh, I've got one more slide here. The last thing I want to talk about is the liquid gold hair concentrate, throwing this in at the end. This product is my magic bullet for hair growth. It's like my hero product. But this product is only to be used once you figure out what your root cause is. This product helps to improve the hair thickness and density. but it will do nothing for a vitamin D deficiency. It will do nothing for a thyroid disorder. It will do nothing for low iron. It will do nothing for your hormones. So many individuals, once they've figured out their root cause, they're like, how do I get my hair to grow back as quickly as possible? And it will take time, but the Liquid Gold CHOSA product I've seen fantastic results with personally, and I have so much positive feedback with it. It tastes awful. I will agree. It is the worst tasting supplement that I've created the worst tasting supplement. I will 100% own that, but it really does work and it can help your hair grow back faster and thicker. But you do need to find the root cause first, right? Figure out what's going on before you start taking that. All right, let's go over to the questions and see. Oh, everybody says the chat is disabled. Sorry. So I see some individuals are able to post. Maybe you have to find the Q&A if you're on Zoom. So post your questions in the Q&A because I do see some here. That's my fault on the IT side. What if your iron reading is normal and your ferritin is 3? So remember the progression of iron deficiency. Ferritin is your storage form of iron. First, you're going to deplete your stores, then you're going to deplete the iron in your blood. It's almost like when you have to pay for things, you're going to deplete your savings eventually. So yes, a ferritin of 3 is low, well below the optimal of 80 to 100. And you definitely want to speak to your primary care, your practitioner about, is iron appropriate for you to dose? Personally, what I do in my practice is I try to look for the root cause. Why is your ferritin 3? Are you not getting enough in your diet? Are your menstrual cycles heavy? If they're heavy, why are they heavy? Do you have a hormone-related concern? If you're having iron in your diet, are you absorbing iron? Is there something going on with the gut? So yes, you can supplement with iron, but don't miss the opportunity to figure out why your ferritin is low. Are vegetarian iron supplements effective? So yeah, ferrous fumarate, ferrous sulfate, ferrous gluconate, those are all iron supplements that do not come from animal sources. The only type of iron supplement from animal sources is going to be your heme iron. And heme iron does not contain a lot of elemental iron. I think it's far too high of a price point. I don't see it working as well, actually. I think heme iron from dietary sources, if you're willing to consume red meats, are great. But for an iron supplement, I stick to the ferrous fumarate is my go-to, then ferrous gluconate, then ferrous sulfate. Can I ask, do you eat iron supplements during your menstrual period? So I've had a past history of chronically low levels of iron. And interestingly enough, my iron has been way better now that I'm drinking well water. And my well water is major high in iron. It's causing a problem with my sinks and my bathtub, but my ferritin levels are really great. So I took iron consistently until my ferritin levels were optimal. Then I took it just while I'm on my period. But now that I'm drinking out of well water that's so high in iron, I don't take iron anymore while I'm on my period, but I have repeated my labs. So I know that it's well high, even without that. If I install a filter to get the iron out of my water, then yes, I would resume my ferrous fumarate while I'm on my menstrual cycle. Does a receding hairline, thinning hair around the temples suggest a particular root cause of hair loss? So it depends, and it's sometimes really challenging. Usually around the temples here, I see more as a nutrient deficiency. But in some cases of androgenic alopecia, we also see it here. Androgenic alopecia is very classic, like the part line starts to get wide, the crown here. And if a patient has the part line widening, the crown, they're losing the hair, and they have acne, they have PCOS, they have hair growth on the face, those are even more signs of the elevated androgen state. It's really hard with androgenic alopecia because not always are blood levels of androgens high. Some patients with androgenic alopecia just have a heightened sensitivity to androgens. Maybe they're in perimenopause or menopause and their estrogen progesterone's low, and that's contributing to the increased sensitivity. If the androgens are all normal and we're not quite sure that it's androgenic alopecia, I address other things first. So we have a lot of research that low levels of ferritin, low levels of iron, low levels of vitamin D contribute to hair loss. So if we're not quite sure if it's androgenic alopecia, but you have iron deficiency, then I say let's start that. Let's correct that hopefully within 3 months' time and see how things go. If it gets significantly better, then we don't need to do anything with the androgens. The name of the genetic test for hair loss, it's the trichogen test that does need to be signed by a provider. So that you can order. I offer it on my website. There's a website called Roots that offers it. ROOTS, trichogen test, TRICHOGEN test. I will send over the recording after 24 hours if you're signed up, as long as it recorded properly, which I'm pretty sure it did. And the slides as well, I can include those, no problem. This is a question, will the insurance company cover the blood test? It depends on your symptoms, it depends on your health history, it depends on your provider. For your insurance company to cover them, you would have to have your primary care write the requisition for the labs. If you are ordering your blood work through Rupa Health, this is a cash pay option. And I know Rupa Health accepts HSA and FSA accounts, but they do not direct bill insurance. The Q&A works. How to book an appointment. You can send me a message or connect with Alison. She's my patient care coordinator. She's amazing. There's an online link to book an appointment. Not all appointments are available through that link. So if there's a different time that you want, if that doesn't work for you, just reach out to Alison, and her contact information is all over my Instagram, TikTok. It'll be there for you. Is DHEA levels 646 high? So it depends on the reference range and the units of measure, but 646 generally would be considered high. DHEA can cause hair loss, it can cause hair growth on the face, and it can cause oily skin. It is a hormone that's produced by the adrenal glands, the same glands that make cortisol. So it's definitely worthwhile investigating why that's high. Should I be worried about significantly elevated DHEA levels if my other androgens are normal? It depends on your symptoms. And ideally, looking at why your body is overproducing DHEA could be helpful. Higher amounts of DHEA are anti-aging, right? So one of the rationales for supplementing with DHEA is fine line and wrinkle reduction or prevention. But it's a Goldilocks hormone. You don't want it too high because it can cause hair loss and acne, hair growth on the face. And you also don't want it too low. So it depends, what Sarah might tolerate for a DHEA level is going to be different than what Susie is going to tolerate for a DHEA level. Everybody has a different tolerance or a different sensitivity. Do you recommend taking liquid gold while getting to the root cause? You can take it at the same time. You can. When I had iron deficiency, I was correcting the iron deficiency and I was taking the liquid gold because I just wanted my hair to go back as quickly as possible. The liquid gold is 10 drops once a day. Dissolve it in some liquid or you're going to be humbled. It is the worst tasting. It's so bad. You have to put it in water, lemon water. I usually, the last little bit of coffee, I drop my 10 drops in and I drink it. The studies showing that an increased hair density and thickness was after 5 months' time. Each bottle is going to last you 2 months. So it's not a quick fix. It is something that you have to take consistently. But yeah, if you fix your iron deficiency or your vitamin D deficiency or your protein deficiency or your stress, then that's a great time to take it, but you could take it at the same time. Can thyroid replacement itself cause hair loss? It depends. It depends on the type of medication that you're using. It depends how your labs are improving. And it also depends on your thyroid antibodies. So Hashimoto's the autoimmune condition that causes low thyroid. There's two pieces to that. You need to get the thyroid hormones better, and you also need to treat the underlying immune dysfunction piece. What iron supplements are suitable for people with GI issues? So For individuals with GI issues, it might be worthwhile looking at running a GI map stool test to uncover why that is. Do you have GI issues because you don't have good digestive enzymes? You don't have good stomach acidity? If that's the case, maybe the iron's upsetting your stomach because you don't have enough stomach acid to break it down and absorb it. Do you have bacterial overgrowth? Do you have leaky gut? Do you have high levels of inflammation in the gut? That's most helpful to know that GI map results. Now, if you are having issues with the iron supplement, so the ferrous fumarate has the highest amount of elemental iron. You could drop down to another form of iron with less elemental iron in it, but just recognize that you might have to take it a little bit longer. This might be a 6-month treatment, not just a 3-month treatment. You could try alternate day dosing. Sometimes that helps if it's upsetting your stomach. If it's causing you to be nauseous, try taking it with food. Try taking it before bed could be an option as well. Lactoferrin can help with iron absorption, and sometimes taking lactoferrin, which is high in colostrum, with the iron supplement helps to ease the impacts on the stomach. I wouldn't add any other blood work test for a vegetarian. I think the hair loss blood work bundle is pretty comprehensive. The cost of a consultation with me, my initial rate is $350, and then follow-up appointments, depending on if they're 30 minutes or an hour, are $140 or $190. And to get an appointment, that would be a great question for Allison. If you contact my office, Allison will let you know. She runs my schedule. Ferrosome comes up a lot on my IG feed. With iron, the most important part is look at the amount of elemental iron that's in it and make sure that you're getting a therapeutic dose. So let me just go back to, I believe the ferrosome was on that list. So every iron has a different concentration, and the ferrosome is a liposomal iron. It has 30 milligrams of elemental iron in it. So you're going to have to take 60 to 120. So that means you're looking at $100 to $150 a month for that liposomal iron. Whereas you could take ferrous fumarate for $8 a month. So it just depends. It depends. If that's the one that you want to take, it's best tolerated for you and it's working. As long as the ferritin's increasing and things are getting better, that's all I care about. I just think the ferrosome is really expensive compared to more economical forms of iron. And it's not as well studied. Liposomal iron, heme iron is not as well studied compared to your very classic ferrous fumarate, ferrous sulfate, ferrous gluconate. I wish I knew about UK blood work testing. I don't know of any private labs that will do it. One thing that I've learned through doing a lot of research on hair loss and genetic differences between countries, in the UK, hemochromatosis is more prevalent. So the rates of iron overload is actually higher there. So if you're in the UK and you have higher amounts of iron, that could be contributing to hair loss as well. I was diagnosed with androgenic alopecia, but my androgens were normal. This can happen. So everybody has a different sensitivity or tolerance to levels of androgens. Just because your levels of androgens are normal within the blood do not mean that they're not contributing to the hair loss. Maybe you have a heightened sensitivity to androgens. That makes it really challenging. So you have to look at all the other blood markers. You have to look at the pattern of the hair loss. You have to look at, do you have other symptoms of high androgens like acne, irregular cycles, cysts on your ovaries? Do you have insulin resistance? So I would suggest making sure that we're ruling out all other things before we diagnose it as androgenic alopecia. What about hair thinning in a 17-year-old male? So great question. I would go back to blood work. Test for the nutrient deficiencies, test the thyroid, test your hormones, test your inflammatory levels. The hair loss blood work bundle includes everything. We want to be able to uncover what the root cause is, because if your hair loss is coming from low iron, no amount of supplemento is going to fix your iron, right? If your hair loss is coming from vitamin D, then you just need to take vitamin D, if that makes sense. I was put on BHRT, so bioidentical hormone replacement therapy, testosterone and estrogen because my testosterone was low, but yet I was told I have androgenic alopecia. Should I have not gone on BHRT? So it depends on how the testosterone was administered. I see a lot of hair loss cases from high levels of testosterone, overdoing testosterone. This most commonly happens with pellet therapy in my experience. So the pellets will cause your testosterone to go way, way above the normal physiological range. And that can cause hair loss. And the hair loss can be quite significant. It can take a long time for that testosterone level to come back down. Now, another thing to consider, most doctors are looking at testosterone, but not DHT. So maybe your testosterone was low because it's all being converted to DHT. Maybe you have that genetic predisposition for the 5-alpha reductase enzyme. Maybe your testosterone's low because it's all being converted to DHT. So if you add more testosterone to correct the low testosterone, that's actually going to make things worse. That's going to really flare an androgenic alopecia case. That's why it's important to look at before I would ever do, I don't think I would ever do a pellet therapy personally. I just don't think overdosing testosterone or high dosing testosterone like that is a great idea. You want to make sure that you understand what's going to happen. So if you take testosterone, what is your genetic predisposition to convert it to DHT? The trichogen test can help that. The blood work test to look at your estrogen, progesterone, testosterone can also be valuable. I'm a big fan of testosterone replacement therapy. I've used topical testosterone replacement. I think it's fantastic, but I just am not a huge fan of pellet therapy in particular. How long does it take for hair to grow back after telogen effluvium? So telogen effluvium, hair loss normally starts a couple months after the stressor, and depending on what that stressor was, will dictate how long it takes for the hair to grow back. So if it's mental emotional stress and that stress level goes away, it could take 3 to 6 months. If it's iron deficiency that triggered the stress-induced hair loss, that hair is not going to grow back until you correct the iron deficiency. My thoughts on collagen. If you're going to take collagen, I would take Verisol collagen, Verisol, Verisol. That is most studied for hair, skin, and nails. Does hair thinning on the eyebrows, could be thyroid, might want to consider that. There are certain provinces in Canada that I can see individuals, and certain provinces I definitely cannot. BC, I cannot. Alberta, I cannot. Ontario, I can. Saskatchewan, I can. I would have to check other provinces. I don't know offhand. If you can send me a message, I can have a look. Would I ever use minoxidil for hair loss? Great question. And I can't believe I didn't include minoxidil in the presentation. So I always think it's important to look for the root cause. Minoxidil is approved for all types of hair loss. So that's why it's kind of given as this magic cure-all. Minoxidil might help the circulation, your hair grow back, but it's not going to correct a vitamin D deficiency or an iron deficiency. So you have to look at that. The other thing with minoxidil is you do have to use it consistently and be committed to using it long term, because once you stop it, we can see hair loss with that. Now, not everybody will have a positive response to minoxidil. Some patients lack the ability to convert minoxidil to minoxidil sulfate. The trichogen, the genetic test, can tell you if you're going to be positive, a positive responder to minoxidil. So if you have good enzyme activity and you can take minoxidil, activate it to minoxidil sulfate, it can work really well for individuals. If you can't take minoxidil and activate it to minoxidil sulfate, it is not going to be as effective for you. So personally, I would have a really hard time doing minoxidil topically twice a day for the rest of my life unless I really, really had to. So again, I would look at the trichogen test, see if you have the genetic activity that you can actually get benefits from the minoxidil. If you can, great. Oral minoxidil is the same. So if you don't have the ability to convert minoxidil to minoxidil sulfate, it's not going to work as well for you. And the other thing with oral minoxidil is it can cause hair growth all over the body. Not in everybody, but just something to consider. And this is where the treatment is very individualized. And on one-on-one consultations, we go through your history, your blood work. We'll talk about all of the different options. We'll brainstorm the pros and the cons, what the research has to say. And then you choose the treatment plan that you feel most comfortable with based off of being provided all of the information. And then, if we're working on something, we're usually repeating the labs in 3 months' time and seeing are things getting better, but we're always trying to fix the root cause. I think that's the most important. Minoxidil, yeah, it has some research on it that it can really help with hair growth if you're willing to commit to it. But it doesn't fix the root cause. So I don't think it's a bad thing, right, to fix the problem that you're having, but still look at the root cause. Okay, let me scroll up here because I think I missed a couple more questions. I'm going to do a couple more questions and then I've got to get my kids to bed. Question about what should my insulin resistance score be? If you're referring to the HOMO IR, I like to see it less than 2. How can I get all this blood tested? You can order it. There is a link in my profile that says order your own blood work. You can order it there, or you can take a screenshot of the hair loss blood work bundle, all the markers, and take that to your primary care and ask them to run it for you. And I know we covered a ton in this presentation. I have other free presentations. There's one on thyroid, one on insulin resistance, one on gut health, so you can check those out as well. I need to get my kids to bed, and I've been talking for so long that I had such a great time doing this presentation. Thank you for joining. But after a long day of work, and then I think we're almost at 2 hours of the presentation, I'm ready for bed, and I'm sure you guys are ready for bed too. So I hope you found that information helpful. If you want to set up an appointment, reach out to Allison. If you have other questions that I didn't answer, send me a message. I'm happy to do it. You're just not getting the best version of me at this point. So I'm going to have a good night's sleep and then answer any of the additional questions tomorrow. So thank you guys for joining, and we'll see you next time.